All right, good afternoon, everyone. On behalf of CME Outfitters, I want to welcome you to this webinar. It's called Intercepting Inequities, Strategies for Improving PrEP Uptake Among Black Americans. And this program is supported by an educational grant from Gilead Sciences, Incorporated. My name is Dr. David Malbranch. I'm an internal medicine, sexual health, and HIV expert based here in the wonderful city of Atlanta, Georgia. And today I'm joined by the illustrious, the famous, the world-renowned Dr. Quentin Robinson, who is an infectious disease specialist at Absolute Care Medical Center and Pharmacy in Atlanta, Georgia. Quentin, welcome to our program today.
Thank you. Thank you.
And thank you for joining us. Okay, so the learning objective for today, and this will be a half-hour session, is we're going to be addressing racial disparities or racial inequities in the initiation of PrEP among Black Americans by initiating two new strategies for HIV testing and prevention into your clinical workflow. And we're going to start with a patient case that you're going to see is going to be presented in video format with two simulated participants, a physician and a patient. And for this patient case, it's Derek. He's a 24-year-old man who's in a monogamous relationship with a male partner who is living with HIV and currently not virally suppressed. He reports that his condom use with anal sex has been routine, but admittedly not 100%. And Derek is not living with HIV currently. He has an unremarkable medical history and no history of STIs. He currently comes to you seeking a prescription for PrEP. So in this scenario, you're watching as the provider and he's coming in. So let's roll the tape and show this video right quick.
Hello, Derek. I haven't seen you in a while. I hope you've been well and safe during these crazy times.
Yes, hi, Dr. Jenkins. Yes, I'm well. I'm happy to report. So far, so good. No exposure to COVID. I've been vaccinated for a while now. I haven't even put on any of that COVID weight.
That's great. I wish I could say the same thing about gaining a few extra pounds. So what can I do for you today?
Well, I wanted to talk to you about a prescription for PrEP.
Oh, okay. But you're monogamous and not exposed to multiple partners. So why don't you just use condoms?
Well, we do, but I can't tell you with a straight face that they are 100%. And so that just seems like playing with fire.
Okay. But you know that PrEP doesn't protect you from other infections if this relationship doesn't work out or if you do start playing the field.
Yeah, I do understand.
Okay.
Dr. Jenkins, is there something else going on and that's making you hesitant about PrEP?
All right, Quentin. So we just saw that video with Derek and his medical provider. Initial thoughts, reactions to that?
So I think when I saw it, my first initial reaction was just, to give, Derek kudos for actually coming to his provider asking for PrEP. I think that's one of the things where we definitely need to talk a little bit more about how you can empower patients to request what they need.
Yeah, I think that's a great point. And what I noticed about the video is that basically they were all happy and chummy for a little bit. And then as soon as he mentioned PrEP, it took a left turn. And all of a sudden the provider kind of mentioned some other things and kind of discouraged him. And you could see his response was a very visceral one. Yeah. Is this a common scenario that you've heard from other patients or you've seen other patients experience in your practice?
Yeah, I definitely have seen that, patients, because as an HIV specialist, I usually see patients who are living with HIV. So I do have a significant number of patients who come to me for prevention. And then we, ask that question, well, have you had this conversation with your primary care provider? And, some of them, their response was, well, I brought it up, but they didn't seem comfortable talking about it. Or I had one patient say, well, they don't like to talk about things down there. And using those words is what the doctor said. So definitely, I've heard stories like that where they've kind of been, discouraged or kind of turned off from a previous provider.
All right. Yeah. Unfortunately, it's a more common scenario than we want to admit. So let's have you talk a little bit about some of the structural barriers that we see to PrEP as far as patients coming into medical spaces.
Exactly. So, with this conversation this afternoon, we're specifically talking about PrEP adoption amongst Black Americans. And we know just from prescription data out there that the growth of PrEP is slower among racial and ethnic minorities, specifically Black people. And a lot of that can be attributed to experiences of homophobia in healthcare, some uncomfortable conversations about sex where the provider just doesn't, understand the language or comfortable talking about it. We talk about racism in healthcare and, even more broader, systemic racism or structural racism in terms of how healthcare systems are set up to either discourage or have, specifically Black Americans kind of not seeking healthcare. Then we talk about other things like physical barriers, specifically looking at those South and rural areas. Some patients have to travel an hour or 2 hours to see a provider who's comfortable prescribing PrEP because the providers in their community either don't know about it or just don't have those conversations. And then the other social determinants of health, inadequate housing, food insecurity, conversations about sexual health in general can foster some distrust between providers and patients, and that impacts the communication and specifically some shared decision making. And then talking about it from the prescriber perspective, what are these deterrents of PrEP prescribing? And again, it's an undercurrent of kind of what society is. We talk about sexual orientation bias, impacting, PrEP access. Heterosexism is the norm, and so or the supposed norm, and talk about attitudes and stereotypes. So providers may have this preconceived notion that, promiscuity, irresponsible behavior usually are ascribed to men who have sex with men. A lot of providers talk about risk compensation where, they're taking a pill that's going to decrease their risk of getting HIV. They're probably going to use condoms less. And then they have that conversation, they're going to use less condoms. They're going to have more frequent sexual partners. And then this other undercurrent about, well, are you really going to take a pill every day when you're kind of like to prevent sexual transmission of HIV? And then, we have this concept of racial biases, and specifically when we talk about the impact of HIV on communities of color and on Black, MSM, some providers have this bias that because more Black men who have sex with men are being diagnosed with HIV, that they're also engaging in more condomless intercourse. And that honestly is not necessarily the case.
Right. I would agree with that. It's interesting because it actually pans out in this study that came out probably about 3 years ago. And you can see this was actually a study where they examined medical students that were having simulated cases of MSM coming in seeking PrEP. And you can see that a majority of people thought it was, that perceived it to be more likely that they were going to increase condomless sex if they prescribed it. They didn't think so much that they were going to have extra relational sex outside of their primary partners. And they did believe that folks were going to be adherent to PrEP. But you can see on the bottom bar graph there, the intention to prescribe PrEP. About 77% were either probably yes or definitely yes with these simulated patients. But then there was still about 23% that were either maybe or probably not. And that's a good quarter. So you can see where those gaps kind of fall in with that, particularly early in training with medical students. And then when you kind of look at the relationship of what's happening between discrimination, medical distrust among sexual minority males, it's another acronym for men who have sex with men. It starts with discrimination that you can see, systemic racism, sexism, homophobia, transphobia, leading to medical distrust. And then that affects health behaviors. So people won't show up for their visits, decreased willingness to disclose their partner's status to provider, their status to the provider, and then a decreased acceptance of new medications or technology that may come out. So it's important to know that it doesn't just exist in a vacuum. It's not just, well, what is their problem that they're not taking PrEP? Sometimes it's the social context and the medical context that is influencing that behavior. And then finally, this was a study that was surveying Black and white MSM that was in a review that I published with Ken Mayer and Allison Agwu, where they talked about conspiracy beliefs that were endorsed more likely by Black than white MSM participants. And these two quotes you can see in this slide: the CDC cannot be trusted to tell gay communities the truth about PrEP. When it comes to PrEP, drug companies are lying and taking advantage of us. You can see that those beliefs and those attitudes don't come out of a vacuum. Again, they're very much based in history and present of things that are going on, why people don't trust medical systems. But it's important as us, as medical providers, to understand that this does exist, listen to our patients' concerns, and then understand that this may be a reason why a lot of Black MSM, cisgendered women, and transgender women really don't want to participate in these trials, or engage in PrEP at some point. And I think you're going to talk a little bit about social determinants. Yeah, sorry.
Yeah, definitely. So, it's not just, attitudes and mistrust that factor into these inequities. Again, there's these other social determinants, like we mentioned before, specifically like what I see, here in Atlanta and in Georgia, transportation, getting to a provider who's willing to prescribe PrEP. Even though it's a little bit different, when I was a medical student, we had to do rural medicine, and there was a patient living with HIV in Waycross, Georgia, which is like about 4 to 5 hours away. But he would come to Atlanta every 3 months to get his HIV care. So think about, in that community, what's their access to HIV prevention? So are patients having to travel long distances? And then, there are some time constraints. I think that's more of a structure of the healthcare system where they're, forcing providers or having providers see patients in a shorter period of time. And sometimes it's not adequate to have a conversation about sexual health and risk.
Right.
Again, looking at the other part we talked about in Black communities, 38% of, patients have to drive more than an hour to use PrEP. And then people in areas of high density, like in Atlanta, there are a lot of people using PrEP. But if you go outside into the suburbs or in Southern Georgia, you're not going to see that. And then, there's significant and limited access to quality medical care and LGBTQ sensitive areas, talking about access to gender affirming hormone therapy, talking about, transgender populations, how is the healthcare system equipped to deal with those circumstances? So those are a lot of the other things that kind of, foster these inequities. So how do we create change? What do we do in the healthcare system as healthcare providers to kind of dissolve these inequities? Education is always key, in the community-based education, to talk about implicit and unconscious bias helps to instill trust in the healthcare system. And again, this falls on the providers to kind of recognize what their biases are and not necessarily see them as a good or a bad thing. It's like, I need to work on changing how I see things or see people or how I react. We can't say this enough. We need more Black healthcare providers in the community as trusted sources of knowledge. I always like to go back to the AAMC study that says there are fewer Black men in medical school now than there were in 1975. So there's a significant need for Black healthcare providers. Really confront head on these, this idea of risk compensation that kind of has providers reluctant to prescribe PrEP. Talking about HIV prevention and talking about sexual health is not going to cause someone to engage in more condomless intercourse or have more frequent partners. Provide positive messaging to patients, in your waiting room, in your social media, in your ads. Talk about, how sexual health is health care and how it's important to help change attitudes and reduce stigma. And then, support those prevention messages through, monitoring and testing. The CDC always gives, guidelines on when to screen and who to screen for HIV, how often to look for STIs. And we really should, as healthcare providers, incorporate that more into kind of our general practice. Because if you're between the ages of 13 and 64, you should have had at least one HIV test in your lifetime.
Right. I couldn't agree more. I want to remind people too that we're going to be coming up on questions in a few minutes. So if you want to start typing up, if you have any questions based on these slides or comments, go ahead and put some of them in now. And then when we stop with these slides, we can actually get to them pretty quickly. So creating a safe and welcoming environment, I think, Quentin, you touched on a lot of the good stuff that we can do and some of the practical approaches we can take, discussing sexual health and PrEP. So it has to be a really patient-centered approach that focuses on health instead of just, we don't want you to get that STI and we don't want to judge you because you're having an STI, but focus more on health and pleasure as a part of sex rather than just disease. And then training staff in cultural sensitive terminology, gender inclusive language, basically cultural humility programs will help along in this process. And it's not just healthcare providers, but everyone in the staff, from the custodian who works there to the front desk person to the navigators, everyone should be part of this training. And then also just building a culture that reassures the patient that the practice is confidential, safe, affirming, and a non-judgmental space. I think when people come into these spaces, if you have the technology, but then it's an uncomfortable and not affirming space, you really can't get the benefit from the advances in science that we've achieved so far. And there's also a lot to be said for healthcare team collaborations that expand the opportunities for PrEP prescribing. So this is just a list and not all inclusive of everything, but just some of the things that are getting PrEP out there more that I think can address some of these racial inequities that we see based on bias and other structural determinants. So HIV screening and PrEP prescribing in emergency departments, I can't tell you how many times I've seen patients come to me for post-exposure prophylaxis because they went to the ER and the ER denied them. So if we can access that and leverage that, that'll be helpful. Utilizing our amazing resources of qualified NPs and PAs in over 3,000 retail health clinics nationally will help. There are pharmacist-based PrEP initiatives that are amazing. And a quick shout out to Meredith Laura at Emory University and Grady Hospital, who has a great pharmacist PrEP initiative over there that is really helping getting people access to PrEP who otherwise wouldn't get it. And then finally, the opportunity to establish partnerships between medical, public health, and social services. One of the things that's not on this list that I thought about while reading through this is just how telehealth with the pandemic has actually become incorporated. So just people knowing that there are programs that you can do where you can get people on PrEP and either work out home testing of some of the required tests you need, or have them contract, or you send a prescription for whatever labs you need to a local LabCorp or Quest, whatever pharmacy you may have a contract with. So that way people can get it without actually physically having to go to a brick and mortar building. Because like Quentin, you said, transportation sometimes can be a problem, particularly in rural areas. And so this is the last slide before we get into the questions and answers. So we look at the goals, and this is the acronym SMARTS for specific, measurable, attainable, relevant, and timely. So again, addressing the social and structural systemic barriers to PrEP, combating these social biases and not being afraid to talk about them and bring that up and actually reflect them back to people, especially our colleagues who may not realize that they're part of these biases, and people may think they're doing things well. And you're like, no, boo-boo, you're not doing it as well as you think you are. And you may have, isolated this person or triggered this person with some of the comments that you made. That's going to be important. Recognizing the presence and manifestations of distrust in the medical community, where that comes from, and listen to it and instead of saying, why do you distrust us? Ask the question, what can we do to foster more trust from these communities? Meeting the patients where they live with positive messaging about PrEP to reduce stigma, and then building a team-based culture that's welcoming, safe, affirming, and non-judgmental. I can't tell you enough. Folks are getting judged enough in their personal lives as it is. The last place they need to be judged is in a medical space that they think is supposed to be welcoming and non-judgmental. Okay, so that's the completion of the presentation, and we've already gotten a few questions, so we're going to jump into the questions now. And I just want to remind everybody, if they have questions, go into the chat and put it in for us. I'm Dr. David Malbranch, again with Dr. Robinson. First question we're gonna address here, Dr. Robinson, is while PrEP is covered by insurance, sometimes the follow-up labs are not. Do we have any tips on that? Because one of our audience members is worried about losing a patient to follow-up. Because the insurance won't cover the follow-up lab. So what tips do you have for them?
So tips, I think the first tip would be, pay attention to how you code your visit. I think that's kind of the key just to avoid any hiccups. It's just making sure that you're using the appropriate codes. Myself, when I have a patient for a PrEP visit, I probably use about 4 codes for that visit to cover the prescription and the lab. But interestingly enough, we had mentioned in the presentation that the Centers for Medicaid and Medicare Services said as of July 30th that most insurers are required to cover the clinic visit, the labs, and any other associated fees without any co-pays or co-insurance or deductible payments made by the patient. So they have about 60 days to kind of comply. So we're coming up on that, where most insurance companies should cover the labs associated with PrEP at no cost to the patient.
Yeah, so if you're a provider and you've been having trouble with that, with the insurance companies kind of pushing back, then you may have some relief coming around in the next week or so. And I think a lot of it also comes from the U.S. Preventive Task Services Force giving it a grade A recommendation as a preventive service. So again, commercial insurers have to cover for things like colonoscopies, mammograms, flu shots, those kind of things are included in the premium. So it's good to see us advancing with PrEP being a part of those preventive services that are officially being recognized by, by national, organizations and stuff like that. So let's go to second question, Dr. Robinson. Are you allowed to prescribe PrEP via telehealth? And do you ask them to get labs done first and then prescribe?
So yes, you can prescribe PrEP via telehealth, and it is ideal to get labs done first and then prescribe, primarily because you want to make sure that someone is HIV negative before you prescribe PrEP and actually have them pick up the prescription. So it's important to make sure that you have that negative HIV test prior to prescribing it.
Right. And there are, I mean, between a lot of different clinics, community-based organizations, I would say healthcare centers, as well as kind of independently owned private companies that do PrEP via telehealth, it's becoming increasingly a big part of PrEP provision. And so, like Dr. Robinson said, I think the main thing is that you want to confirm that they're negative, and whether that may be through a swab antibody test, or if you have the capacity to do serologic testing and check for the 4th generation antigen antibody combo. Either way, just as long as you know that they're not living with HIV, because if they are seroconverting or if they are living with HIV, obviously if you put somebody on either FTAF or FTDF, then you're going to risk some kind of resistance because it'll be an inadequate treatment. Okay, next question. Any recommendations for brochures and or handouts that you found to be useful in your practice?
So that's kind of a broad question. I think there's a lot of resources out there. You know, the first place I would go is definitely the CDC. I mean, CDC has plenty of resources in terms of handouts, pamphlets, and posters that are available describing PrEP. The second place I would say is your local health department. Your health department and your state health department should also have promotional material for PrEP. And then, you know, lastly, you could look at specific marketing material related to either generic or brand name prescription drugs for PrEP. So I think all of them are equally good. I don't think one is better than the other. I think just getting the information out there that there is, you know, a pill that you can take that will decrease your risk of getting HIV. I think that's the message, and there are plenty of resources. So the CDC, your state and local health departments, and even branded material from pharmaceutical companies.
Yeah, and I would even say two of the health departments that are particularly progressive and have some great information is the New York City Department of Health and the San Francisco Department of Health. And again, if you don't see it reflective of your community and the people that you're prescribing to, because there may be some providers out there that are primarily with cisgendered heterosexual women, there may be an OBGYN that's working and sees a lot of it and says, well, is PrEP really for cis women? Because I'm seeing most of this around gay men. And so you can create your stuff as well. And sometimes you can partner with your Department of Health or call the CDC, and they'll be happy to work with you on those things, or maybe find some way to get some of those materials for your patients. All right. We mentioned, we had another question about the CMS rule, so you addressed that a little bit earlier. So Dr. Robinson, this is a good question. How do you decide between FTDF and FTAF?
So I think that's a clinical decision without getting into too much of like that individualized patient care. It's a matter of, you know, one, the unfortunate or fortunate, however you look at it, is, you know, what's covered by insurance. That's one. Two, in making that decision, you want to take in the clinical status of the patient. Do they have existing, you know, kidney or bone disease? Do they have risk factors for kidney or bone disease? Are they concerned about, you know, things that may happen along the line? I think both of the drugs that are available now are equally effective in decreasing the HIV risk. It's really an individualized kind of taking into account each individual patient's characteristics.
Yeah, I think with my patients, I take into account kind of comorbidities. I'm also looking into the age as well, because some of the youth, you know, you have to make these considerations of, you know, adolescents and young adults are kind of laying down bones. So some people would consider FTDF as something that would be problematic, even though some of the bone changes that you see can be reversible once it stopped. Some people may lean towards FTAF for that very reason. And then also with younger populations that I consider, and with everyone for that event, we do mention there's a possibility of some weight gain that some people can get with the FTAF regimen. It's not going to be as great of a weight gain when someone is living with HIV and treated with TAF plus another treatment category called the integrase inhibitors, but it's still a consideration for people who are body conscious or worried about that kind of stuff. When I've had these discussions, they've immediately shut it down. Like, is that going to make me cause weight, or is that the potential to make me cause weight? I'm not going to do it. So I think as providers, we have to really get involved in this and be active with our patient and ask them what their main priorities are and what their concerns are, what they've heard on the internet. That's one of the big questions that I use. I'm sure you use that as well, Dr. Robinson, but I'll say when they express a concern or when they come in about PrEP, I'll say, well, do you know anybody who's on PrEP? Or what have you read in social media? What have you heard on TV? What have you read in the news outlets? And then gear it by what they've heard so you can combat any misinformation that may be there.
Definitely.
All right, so one of the final questions, I think we have time for maybe one or two more. What was the statistic on Black healthcare providers in the 1970s? Les, it went by quickly and I missed.
So what I had mentioned was referencing a study by the Association of American Medical Colleges. And what they found was that, I want to say it may have been 2019, 2020, that there were fewer Black males in medical school now than there were in the late 70s. So when we talk about, culturally competent or healthcare providers or the HIV and HIV prevention workforce looking for other providers of color, specifically men, there are actually fewer men in med school now than there were in the late 70s.
Yeah, and that's a striking statistic. And I think, for me and for a lot of other Black men that have been in, we've been in the field for a little while, it's kind of disheartening to hear that, especially when we see the inequities that are panning out with HIV, with uptake of PrEP. So you have to realize that representation is important, not only from the healthcare provider standpoint, but also ancillary staff, anyone else that's working in the clinic. If you have it that's more reflective of the community, the uptake and the trust may be something that we can get involved there. We're about to wrap up. I don't think we have any more questions, but I wanted to ask you, Dr. Robinson, any final thoughts or comments or suggestions to those providers out there that want to start PrEP, maybe dealing with some of these issues that we've talked about in the presentation about how they can best move forward?
So I think, in terms of providers who may be hesitant or providers who are actually interested in starting to prescribe PrEP, I think a couple of words of advice is, one, definitely utilize the CDC resources. The CDC has a fantastic document on how to implement PrEP, and they also have a provider's supplement specifically for healthcare providers, covering questions about what labs to order, when to order those labs, how to code your office visit. So I think CDC is a fantastic resource. And then, look to your community, reach out to those healthcare providers who are actually prescribing PrEP. If you have questions, reach out to trusted colleagues that and say, how did you start doing this? How can you help me move forward and do this better or more than what I've been doing?
Right. I think that's great advice. Of course, now that I say we have no more questions, one just popped up. So we'll take this last one because we have like 2 minutes and we'll be able to get through the closing pretty quickly. Sometimes social media is good. Sometimes it is my worst enemy. Negative messages about the use of PrEP in transgender women who are on hormone therapy is a great example. Any tips for tempering that urban legend down? Dr. Robinson.
So urban legends are hard to kill. However, I think if you have questions about use of PrEP and specifically in persons of trans experience and interactions with hormone therapy, ask the healthcare provider. I think that's your best place to go, or even some of your community-based organizations. I will say this, though, that both drugs that are now available for HIV prevention and PrEP are indicated for transgender women. And there has been no known drug interactions for those who are on gender-affirming hormone therapy. So if you didn't get it from your social media, you got it here that, trans women who are on hormone therapy can take PrEP.
Yeah, and the simple thing I will say to that is that the urban legend goes that if you're on PrEP and you're a person of transgender experience, particularly a transgender woman taking estrogen, the urban legend was that the TDF or the TAF will actually reduce the efficacy or the availability of your hormones, so they won't work as well. It's actually in a little bit of the reverse, where the hormones may actually prevent particularly with Truvada or TDF, from working as well. So if you have women of trans experience who are on estrogen, just encourage them to make sure they're taking their medication every day so that it's going to be as effective as you want it to be. All right, we'll end on that note. Thank you, Dr. Robinson, again for this conversation.
Pleasure.
It's always a joy. And I want to thank the audience for your questions. If you or any of your colleagues missed today's program, Let them know that there's a final opportunity for question and answers on Friday, October 1st at noon Eastern Standard Time. And for additional CME and CE activities, please check out the CME Outfitters website at www.cmeoutfitters.com. And for patient education, the HIV patient education has a lot of resources, videos, and downloadable resources to share with your patients. So please, everybody, stay safe, incorporate sexual health and PrEP into your repertoire. Thank you for participating and have a great, great weekend.
Never be the same